Biliary organs include the liver, pancreas, and gallbladder. They're also called the accessory organs. Each of these organs secretes fluid to aid in digestion and metabolism, and each organ has a duct that enters into the duodenum through the sphincter of Oddi. The pancreas has the pancreatic duct, the gallbladder has the cystic duct, and the liver has the hepatic duct. All ducts merge with the common bile duct. Inflammation in one organ will affect the other two. For example, when gallstones lodge in the ampulla levator, the flow of bile and pancreatic secretions is impeded. 500,000 surgeries per year are performed on the gallbladder. The gallbladder, also called the cholecyst, stores bile and aids in digestion. It is attached to the liver by the cystic duct. The gallbladder stores about 50 mL of bile at a time, and that gets released when fatty food enters the duodenum. The bile stored in the gallbladder is more potent than that stored in the liver because the gallbladder concentrates the bile. Cholecystitis can either be acute or chronic. Acute coli usually develops because of stones. Acute cholecystitis might also develop in the absence of stones, and acalculous cholecystitis, due to poor flow to the gallbladder or poor emptying of bile from the gallbladder. There might be some kind of anatomical problem, such as a twist in one of the ducts. Stones or calculi get trapped into the ducts, and the bile gets trapped and then sits in the gallbladder, irritating it. Consequences? The irritated gallbladder will get necrotic and gangrenous and might rupture, and that will lead to peritonitis or an abscess. A gallstone size varies and may be as small as a sand grain or as large as a golf ball. The gallbladder may develop a single, often large stone, or many small ones. They may occur in any part of the biliary system. Cholesterol gallstones develop when the bile contains too much cholesterol and not enough bile salts. Besides the high concentration of cholesterol, two other factors seem to be important in causing gallstones. The first is how often and how well the gallbladder contracts. Incomplete and infrequent emptying of the gallbladder may cause the bile to become overconcentrated and contribute to gallstone formation. The second factor is the presence of proteins in the liver and bile that promote or inhibit cholesterol crystallization into gallstones. In addition, increased levels of the hormone estrogen as a result of pregnancy or hormone therapy, or the use of combined estrogen-containing forms of hormonal contraception may increase cholesterol levels in bile and also decrease the gallbladder movement, resulting in gallstone formation. Stones might be comprised of cholesterol, bilirubin, bile salts, calcium, and protein. 90% of all stones are cholesterol. The gallbladder promotes a great environment for stone formation due to the temperature and its viscous contents. Risk factors for gallbladder disease include family history, obesity, cholesterol-lowering drugs, age, type 1 diabetes, rapid weight loss, gastric bypass surgery, birth control pills, pregnancy, prolonged immobility, excessive opioids, long-term fasting, and prolonged anesthesia. Familial tendencies might be related to diet and exercise habits. Overweight people tend to have more cholesterol in their systems. Cholesterol-lowering drugs lower levels in the blood but increase it in the bile, which can then form stones. The liver will excrete extra cholesterol into the bile during rapid weight loss. Women are twice as likely as men to develop gallstones. The female hormones tend to delay gallbladder emptying. Many of the risk factors mentioned in the slide delay gallbladder emptying. Native Americans are followed by Mexican and white individuals in running the highest risk of getting gallbladder diseases. Clinical manifestations of gallbladder disease include biliary colic pain, Murphy's sign, rebound tenderness, jaundice, steatorrhea, and older clients might have atypical signs. So the signs and symptoms: pain triggered by fatty food. Pain is vague and tends to be located in the upper quadrant. The patient will have anorexia, nausea and vomiting, dyspepsia, sense of abdominal fullness, fever, and possibly jaundice. Murphy's sign equals a right subcostal palpation and deep breath, which leads to pain. Rebound tenderness, pain that increases when you stop palpating. Fatty stools might occur because of fat malabsorption, which comes from a lack of bile entering the intestines. The best way to diagnose gallbladder disease is through ultrasound or hepatobiliary scan, a HIDA scan. The patient lies flat on the imaging table and receives an injection of a radioactive substance. During the scans, the camera is positioned over the patient, and images are recorded for up to 1 hour, or rarely longer. For some patients, a second injection through the same needle stick will be done later during the test. This can be done to either help the gallbladder show up better using morphine, or to trigger it to empty using CCK, cholecystokinin. Initial treatment often involves resting the inflamed gallbladder with a low-fat diet, or even making the patient NPO. Narcotics. Nowadays, morphine is used, although the theory is that meperidine is better for decreasing contraction of the sphincter of Oddi. May be given to relax the gallbladder and the patient. Antiemetics might be needed since the pain and nausea go together. A stent may be placed to open closed-off ducts. Cholecystectomy, or laparoscopic cholecystectomy, the surgeon makes a midline umbilical incision into the abdominal cavity. It's inflated with 4 liters of carbon dioxide. Other small incisions are made for forceps and retractors to be used, and the gallbladder is removed through the umbilical port. Patients are discharged in 1 day, but might need an overnight stay if pain and nausea are too much. A traditional cholecystectomy is an incision in the right subcostal area. A T-tube is inserted due to the common bile duct inflammation, and a JP inserted too, and that requires a 2 to 3 day stay. After a cholecystectomy, patients should attempt to maintain a low-fat diet or consume fat to their level of tolerance, with no more than 20% of their daily intake containing fat. The pancreas is unusual in that it is an endocrine and exocrine organ. It secretes digestive enzymes into the duct, making it exocrine. It also secretes insulin and glucagon directly into the bloodstream, making it endocrine. The bulk of the pancreas is made up of cells that make pancreatic fluids. The pancreas is a fish-shaped organ with the head located behind the stomach and the tail behind the spleen. The condition pancreatitis ranges from inflammation and edema to complete tissue destruction and necrosis of the pancreatic cells. The normal pancreas secretes pancreatic juice, which flows down the pancreatic duct and merges with the common bile duct. Pancreatic juice is made and secreted and travels down the pancreatic duct into the common bile duct. The pancreatic juice is made up of bicarb to neutralize the stomach acids, trypsin to digest protein, lipase to digest fat, and amylase to digest sugar. The parasympathetic system leads to further release of pancreatic juices, and the parasympathetic system increases digestive activity and slows down the heart rate and contractility at the same time. The common bile duct and pancreatic duct join to form the ampulla of Vater and empty into the duodenum. Where the ducts merge and empty into the duodenum, there is an opening surrounded by a muscle called the sphincter of Oddi. The sphincter of Oddi regulates forward motion and prevents reflux back into the pancreatic tissues. Sometimes problems with the pancreas stem from an inability of the sphincter of Oddi to open and close regularly. The endocrine function makes up about 20% of the organ, with islets of Langerhans secreting insulin and glucagon directly into the bloodstream to regulate sugar. Alpha cells secrete glucagon, a hormone that causes glycogen to be released from the liver. Beta cells secrete insulin, a hormone that gets sugar from the bloodstream into the cells. The main exocrine role of the pancreas is to secrete the juices that contain enzymes that become active when entering the digestive tract, specifically the duodenum. The pancreas secretes about 1 liter of juice per day. Even when we are not eating, there is still juice and bile in the digestive tract. Pancreatitis is a condition where the pancreas becomes swollen, red, and painful. It becomes inflamed because the pancreatic juice backs up through the pancreatic duct back into the pancreas, damaging the pancreatic tissue. It can run the gamut from mild inflammation to serious tissue damage and internal bleeding. The usual causes are common bile duct obstructions or alcohol abuse. The number one cause for women is obstruction of the common bile duct, leading to reflux of pancreatic juices into the pancreas, inflaming the tissue by activating digestive enzymes. Alcoholism is the number one cause for men in the U.S. Alcohol leads to spasming of the sphincter of Oddi and swelling of the ampulla of Vater, obstructing the flow. Alcohol further leads to more hydrochloric acid, which causes the pancreas to have to work harder. Also, the duodenal contents can seep through if the sphincter of Oddi doesn't close well. The duodenal contents can get into the common bile duct. Gallstones can travel out of the cystic duct and lodge in the common bile duct, blocking the juice and the bile flow into the duodenum. It backs up into the pancreas where enzymes are activated, and the activated enzymes start to break down the pancreatic tissue. The clinical manifestations include weight loss, jaundice, pain, Cullen's sign, Turner's sign, and altered lab values. Weight loss occurs when the patient is unable to eat and has periods of nausea and vomiting. Jaundice occurs due to the bile backup into the ducts. Bile contains bilirubin, and the bilirubin cannot be excreted through the digestive tract. Excess bilirubin shows up through the skin in the form of the yellow color. The pain is severe. It is in the epigastric area, radiating around to the back. Cullen's sign is indicative of internal bleeding and shows up as a blue color on the abdomen, while Turner's sign shows up as a blue color on the back. Cullen's sign indicates pancreatic necrosis, bleeding, and internal hemorrhage. A bluish discoloration appears on the abdomen, and that indicates retroperitoneal bleeding. Turner's sign indicates retroperitoneal bleeding that shows up as a blue color on the back. With pancreatitis, amylase and lipase levels will rise in the bloodstream. Lipase levels will remain high even after the acute episode resolves, so it is a more accurate indicator of pancreatitis. Generally, when amylase and or lipase levels are elevated, you can be sure the patient has pancreatitis. With amylase, anything over 170 microliters peaks falls over 12 hours. For lipase, anything over 280 microliter peaks and falls over 3 to 4 days. Hypocalcemia is a serious consequence that can occur in about 25% of pancreatitis patients. Calcium levels will go below 8 milligrams per deciliter, leading to serious consequences unless treated. Ultimately, it can lead to tetanus. 2 signs of hypocalcemia are Chopsticks and Trousseau's signs. Pancreatitis can also lead to lower levels of magnesium and potassium. Low mag also leads to nerve irritability in the same way that calcium can. Low potassium leads to muscle weakness and can make the heart less responsive. Calcium levels go low due to the process associated with pancreatitis called lipolysis or saponification, which actually means the making of soap. As the pancreatic tissue is injured and destroyed, fatty acids are released, and these fatty acids combine with the ionized calcium to form a soap-like product. These leach out the calcium away from the bloodstream, and hypocalcemia indicates a poor prognosis. The etiology of pancreatitis. Alcoholism is a common reason for acute pancreatitis. Alcohol causes increased enzyme production in the pancreatic juices. It damages the sphincter of Oddi. All of this leads to increased reflux and autodigestion. Biliary tract obstruction makes it so that the bile cannot get into the duodenum, and it backs up into the pancreas, where enzymes again can do damage to the tissue. Idiopathic means we don't know the cause, but for some reasons. Some of the reasons include viral infections, familial tendencies, drug toxicities, such as opiates, sulfonamides, thiazides, steroids, and the birth control pill. Blunt abdominal trauma can also cause, usually from a motor vehicle accident. There are also iatrogenic reasons, such as an ERCP, tumors, cysts, and abnormal structures of the organs can also cause blockages. The ERCP is used to relieve stones that are blocking ducts, opening a narrow duct, or relieving a tight sphincter, a sphincterotomy. A major complication of ERCP is pancreatitis. The risks and the benefits must be weighed. To prepare the patient for the ERCP, the patient must be NPO overnight. The patient will receive conscious sedation during the procedure, and the throat is sprayed to diminish a sore throat. The treatment for pancreatitis. The most important intervention has to do with fluid and electrolyte replenishment. The patient gets dehydrated due to the third spacing from inflammation and from internal bleeding. Also, electrolytes such as calcium, magnesium, and potassium are low. It's most important to replace the potassium. The patient typically needs frequent pain medication dosing, usually morphine or Dilaudid, or ordered to give IV push every few hours. The patient has to be NPO because intake by mouth leads to increased pancreatic juice secretion. Patients who must be NPO for a week or more will need total parenteral nutrition. Sometimes the patient might receive tube feedings with feeding bypassing the duodenal area, a nasojejunal tube, or an NJ. Gastric decompression, an NG tube, might be needed if the patient develops a paralytic ileus. A paralytic ileus results from irritation in the digestive tract from poor food metabolism. Activity restrictions might help to reduce the enzyme secretions. Finally, H2 blockers will decrease the hydrochloric acid. Hydrochloric acid increases in pancreatitis because there is less pancreatic fluid getting into the digestive tract to raise the pH of the fluid. Chronic pancreatitis has many of the same problems as acute pancreatitis. But with chronic pancreatitis, there are structural and tissue changes. The consequences of chronic pancreatitis last over the long haul, and the patient must deal with exacerbations. The pain with chronic pancreatitis is severe and debilitating. High doses of opiates are required since the patient will develop a tolerance. Weight loss occurs due to the patient's inability to eat and from the malabsorption since fat cannot be digested. Ascites can occur from increased common bile duct pressure. The stool has little bile in it, so it takes on a clay-colored, fatty, fair, foul, frothy, floating steatorrhea. The patient with chronic pancreatitis might develop diabetes if the beta cells in the tail of the pancreas are affected. The patient will likely have elevated liver function tests along with excess bilirubin due to the bile duct obstruction. Treatment for those with chronic pancreatitis exacerbation often requires hospital admission. NPO status, TPN, fluid electrolyte replacement, and opiates are often part of the treatment. Chronic pancreatitis can lead to the formation of abscesses or cysts. Cysts are pockets of fluid that become walled off by the tissue. Abscesses are pockets of microorganisms that become walled off. Abscesses are difficult to treat and can become dangerous. To treat an abscess, the patient might go to interventional radiology for a tube insertion. A tube can be inserted into the abscess and flushed periodically. Restrictions for a pancreatitis patient: no alcohol, no caffeine, a low-fat, high-protein, bland food diet. Once a patient has had pancreatitis, he or she should abstain from alcohol and caffeine. The patient will need a low-fat diet and will need enough protein to make up for the fat that can't be eaten. The food should be bland because spicy food triggers more hydrochloric acid secretion and more pancreatic juice secretion. The patient may have to swallow enzymes in order to digest food. With pancreatitis, enzymes back up into the pancreas and can't get into the digestive tract. Enzymes should be taken before or with food. Enzymes will allow absorption of fat and protein. Enzymes should never be mixed with protein foods. And tablets should never be chewed. Common enzyme names include pancrelipase, pancrease, and viocase. Finally, the pancreatoduodenectomy, otherwise known as a Whipple procedure. The duodenum and part or all of the stomach, gallbladder, and all of the pancreas are removed. Everything is rerouted to the jejunum, and the patient is left with a dependency on enzymes and probably insulin too.